Hey everyone, so we're continuing our psychiatric drugs with other antidepressants, antipsychotics, and mood stabilizers. So to begin with, we should first define the diseases that we're hoping to treat with these psych drugs. So depression is our first one that we're going to treat. It's also called major depressive disorder, or MDD. You'll notice in healthcare and psych, they love their abbreviations. So MDD also stands for major depressive disorder. Now, depression is a mood disorder which causes profound feelings of sadness and a loss of interest. So it's often treated with SSRIs or SNRI medications. You can, of course, look to the other video to talk about those specific drug classes, but sometimes other agents are necessary. So as I say, see the other presentation on SSRIs and SNRIs if you want to go into more detail, because that's generally the first drugs used to treat this. But if we require a little bit more, other categories of antidepressants may be prescribed for the treatment of depression. So these medications facilitate or help maintain the correct balances of neurotransmitters in the brain to help treat depressive symptoms. So they're very useful in treating this depressive symptoms or this major depressive disorder if SSRIs or SNRIs are ineffective or if the patient simply cannot take them. Next, we have our anxiety disorders, which again are usually just treated with SSRIs or SNRIs. However, there are instances when we would want to treat them with something else. So people with anxiety disorders frequently have intense, excessive, or persistent worries and fear about everyday situations. So occasional anxiety is normal. I would say I'm a fairly hyped up and anxious person, especially if I drink too much coffee, right? But if it starts to begin to interfere with daily activities, like even going outside or being able to function at work, or double and triple checking things, which you know in your head is probably going to be fine, but did I lock the door? And it becomes a paralyzing type thought, or these intrusive thoughts as well. Treatment could be considered at that point because that goes beyond a normal level or a healthy level of anxiety. So we have many examples of anxiety disorders. Probably the most common being generalized anxiety disorder, or GAD. That's just when you're sort of in a permanent fight or flight mode, and then treatment may be necessary. Social anxiety disorders as well. So that might be a phobia of public speaking, of going in public, interacting with other people. It might be very crippling for people to maintain those work and life relationships if they have a social anxiety disorder. We also have obsessive-compulsive disorder, or OCD. And that is a irrational thoughts and fears that go off in a person's head. Say it's not just, I should clarify, OCD is not just being a neat freak. It can also be these very, very intrusive thoughts where, oh, I touched this doorknob in a certain way in a certain number of times, and that means my family is going to die. The person with OCD understands that, well, it's a completely irrational thing, but their fear, their anxiety is still triggered. And that is sort of the basis of OCD. Now, we also have panic attacks, which can occur as a result of certain traumas. Phobias, which are these irrational fears of sometimes things that are not dangerous at all. Might be a phobia of bees, a phobia of clowns, you name it, there's usually a phobia of it that's defined. And then we also have post-traumatic stress disorder, or PTSD, which may be the result of either an acute or ongoing traumatic situation. Now, as I said before, SSRIs and SNRIs are preferred, as well as benzodiazepines for short-term use. A lot of times you'll see benzos prescribed, especially if someone's anxious before a surgery, say they're getting their wisdom teeth out, or they're going in for a quick procedure at a hospital. If they're very anxious, they might prescribe them a Valium, a diazepam, or something like that, just to take the edge off before they go into the surgery. However, when this is for long-term use, that's usually when we consider using other antidepressants and anti-anxiety drugs. That might be useful, especially if SSRIs and SNRIs are ineffective. So the first of these types of other antidepressant and anti-anxiety agents are our tricyclic antidepressants, or TCAs. Again, as I said, they love their abbreviations, right? So TCAs, the reason why they're called tricyclic antidepressants, you see right there, this is their chemical structure. They have 3 rings. So think of like a tricycle with 3 wheels. These are tricyclic, as in they have 3 circular rings, or well, hexagonal in this case, but we've got 3 rings. So tricyclic antidepressants. So they increase and decrease the levels of multiple neurotransmitters, these chemicals which influence mood within the brain, and they specifically are used on patients with depression. They're useful as well if SSRIs or SNRIs do not work to treat anxiety or any of those anxiety disorders that we were talking about previously. Now, side effects of TCAs, and one of the reasons why they're not as often used as some of the SSRIs or SNRIs, is they do have an increased risk of suicidal ideation when starting the therapy, when starting the drug therapy with TCAs. So suicidal ideation is not actually an increased risk of suicide. It's the increased risk of someone thinking about committing suicide. So they might have more suicidal thoughts, especially if they were already having them or anxious before. So a lot of times we have to advise these patients that, look, you're going to feel worse before you get better, but you just have to stick with it until the medication can fully work in your body, which may be along the lines of weeks or even months, depending on the nature of the disorder. Orthostatic hypotension, which is dizziness upon standing, is also quite common with TCAs. And we also have to have caution in patients with an irregular heartbeat, because a lot of times tricyclic antidepressants can increase a heartbeat, and that can lead to heart problems, especially if they already had, say, some sort of arrhythmia, or they already had hypertension. Dry mouth, blurred vision, and constipation are also pretty common among TCAs. So as I said, that coupled with the orthostatic hypotension is generally why we don't like giving TCAs to older people. So if they're age 65 and up and they might have an increased risk of falling and maybe breaking something, we don't generally want to start them on TCAs for that reason. However, they are quite commonly prescribed. We've got our Amitriptyline or Elavil, and those are just tablets. And then we have our Nortriptyline or Pamelor, again, just tablets. So you see that triptyline, tricyclic, amitriptyline, nortriptyline. So that's a good way to remember at least the generic brands of these TCAs. Next, we have our bupropion, which I feel like comes up in just about every lecture that I end up giving you guys. Bupropion or Wellbutrin, it's used in the management of depression. It's also used to decrease nicotine cravings for smoking cessation. So sometimes you will see the Wellbutrin specifically prescribed to help people quit smoking because it sort of takes the edge off of those nicotine cravings. And it might be a good option for a patient who wants to quit smoking and also wants to, is maybe feeling a little down in the dumps and they have a depressive disorder. So it can be useful in that regard. 2 birds with 1 stone, limiting that pharmacotherapy, and it's easier for the patient to take 1 pill rather than 2 or some sort of patch or lozenge. However, the reason why we don't like bupropion sometimes is that it has lots and lots of drug interactions, especially with other psych and anti-anxiety drugs. So if they're already taking like an SSRI, an SNRI, or some other TCA, you don't want to put them on bupropion because it's probably going to interact. SSRIs and SNRIs are preferred because of all of these different drug interactions that bupropion has. And also the other reason why they're preferred is you cannot use them. You cannot not ever use them in patients with seizure disorders because bupropion, Wellbutrin, increases the chance of seizures. So it lowers what's called the seizure threshold. So the amount of brain stimulation it takes for someone to have a seizure gets lowered. So less effort, less electricity, less chemical signals in the brain are needed in order to induce a seizure in a person who is taking bupropion. And that also happens if you take too much bupropion as well. A person who doesn't even have a seizure disorder is at increased risk for having a seizure. So that's another reason why we especially avoid bupropion in persons with any risk of seizure or epilepsy or similar brain or neurological disorder. However, if you do take bupropion, you can expect a few side effects like dry mouth, agitation, headache, nausea, vomiting, and dizziness. Again, suicidal ideation is another one. That idea of committing suicide is especially more common in younger patients taking bupropion. And as I said, it lowers that seizure threshold. So caution all those patients with epilepsy. Some other ones, we have Mirtazapine or Remyron. You actually see this quite a bit in hospital settings as well. It's a non-tricyclic antidepressant. It actually has 4 circles instead of 4 rings instead of 3 rings like the TCAs do. So it's a tetracyclic antidepressant technically. And again, may cause increase in suicidal ideation. The reason we don't like mirtazapine generally is it's over time, it can cause weight gain. And so lots of people, if they're already depressed, that's the last thing you want to do to them is make them gain some weight, because it has these metabolic side effects in addition to some of the other typical antidepressant side effects. Next, we have trazadone or Deseril. Trazadone is often what's called a fast mover in a pharmacy. You'll see trazadone as one of probably the most prescribed antidepressant drugs. However, it's not usually prescribed as an antidepressant. It can work. It's not a great antidepressant, but it can work. It mainly reduces levels of neurotransmitters associated with arousal or anxiety. So what it's actually pretty useful for is as a sedative or a sleep aid. So some people might be prescribed trazadone just to go to sleep. It calms you down because its main side effect as well is sedation. So you can imagine if someone has anxiety, trazadone might not be the best choice because yeah, they'll be sedated and they won't be anxious, but they also have to function throughout the day. So if they're just sleepy all day, what kind of quality of life is that? So we tend not to prescribe trazadone as an antidepressant or as an anxiety med, but it can be pretty useful in terms of people who might have insomnia or who want a better chance of falling asleep and staying asleep. As a result, the sedation side effects, those sedating qualities, we take both mirtazapine and trazadone QHS. So you want to take those meds at bedtime. So next we come to some of our other psych disorders where both antidepressants and antipsychotics might be used, and mood stabilizers. So firstly, this is bipolar disorder. Used to be called manic depression. We go away from that term now, not just because it's a bit more politically correct, but bipolar disorder is really much more accurate because it's as if people have 2 poles. It's a condition which causes extreme mood swings between mania and depression. So emotional highs, which are known as mania, and emotional lows, which are known as depression. So these mood swings usually last for weeks at a time. So a person will experience mania for weeks and then immediately or quite quickly switch to a depressive state where they feel really, really down and often contemplate suicide and feel very depressed, and it can be extremely difficult for them to function. And it's considered a disorder, of course, when those mood swings interfere with daily life. Now, we have 2 types of bipolar disorder. There's bipolar 1 and bipolar 2. Bipolar 1 is the one that I just described, where you have that mania and that depression. You have both mania and depressive periods. Bipolar 2, however, has periods of severe depression, but no manic phase. So people with bipolar 2 have periods where they are relatively fine and able to function normally. They're not manic, they're not going crazy trying to do everything and hyped up, energetic, but then they have these very severe periods of bad depression. Now, bipolar cannot be cured, but it can certainly be managed with medication and a solid treatment plan. So a lot of times these plans include psychotherapy, so it's talk therapy between you and a psychiatrist or a psychologist, and also treating mood swings as they occur. So a lot of times with bipolar patients, we have to adjust these medications as needed for both manic and depressive phases. And then stability and routine as well is important in bipolar disorder. So oftentimes if a certain thing is destabilizing to a patient, it can set them into an emotional high or an emotional low. So it could be a change in routine. It could be a new assignment on a job. It could be a test coming up. It could be another anxiety inducing event. And that could cause a switch to a manic or a depressive phase. Now, obviously you don't have to remember this, but this just sort of gives you an idea of all of the different symptoms and the truly bipolar, the truly 2 different sides of bipolar disorder. So mania, of course, it includes being abnormally upbeat, jumpy or wired, increased activity, agitation. You could have thoughts of grandeur that, oh, I am the best in the world at doing this and I can do anything, unusual talkativeness, racing thoughts. And then quite often it's characterized by poor decision-making or lack of impulse control. So people will go on buying sprees, spending speeds, taking sexual risks, making foolish investments, sort of thinking they're king of the world and nothing can stop them. As opposed to the depressive phase, where it's characterized by depressed mood, feeling sad, empty and hopeless, tearful especially, marked loss of interest or no pleasure at all in just about all activities, either insomnia or sleeping too much, fatigue, loss of energy. It's quite debilitating. And thinking about planning and attempting suicide as well, which can be a life-threatening symptom of bipolar disorder. And you can just see it illustrated here. So a person in a manic phase, you can see they're up at 3 a.m., cleaning the house, doing the dishes, reading the book online, might last for weeks or months. And then that depressive phase, poor guy at 3 p.m. can't get out of bed because he feels a profound lack of happiness. Next, we have to talk about schizophrenia, which is another very, very debilitating mental disorder. It's a serious mental disorder, which people interpret reality abnormally. That's probably the best way to describe schizophrenia. The cause is also unknown. And you'll see this, and this is why a lot of psychiatric conditions are extremely hard to treat. The brain is an extraordinarily complex organ that we still don't entirely understand. So we don't understand exactly what causes schizophrenia. We have some guesses. We know certain neurotransmitters and certain chemicals in the brain might be off in patients with schizophrenia, might have abnormal levels. It might just even have to do with sort of the wiring of the brain itself. But a lot more research needs to be done in people with schizophrenia. Symptoms of schizophrenia include delusions, which are false beliefs not based in reality. A lot of times, schizophrenic patients may feel that they are being watched. They might feel that the government is spying on them. They might feel that they were, say, abducted by someone. They might have these terrifying fears that they completely believe themselves, but that make really no sense when they're explained in reality. Hallucinations as well add to this issue with people with schizophrenia because they can see or hear things that don't exist. So many people with schizophrenia may hear voices or noises, knocks on the door, doorbells ringing. They might believe that people are outside watching them. It's quite terrifying, especially for people who might not understand that they're sick. Another symptom of schizophrenia that's really emblematic of schizophrenia and helps people diagnose it is disorganized thinking or speech. And so a person with schizophrenia might answer questions that might be partially or completely unrelated with words, what's called word salad. So you might ask, oh, how are they doing? And a patient with schizophrenia might say, oh, who was watching me today? I was going to the store. I saw someone. That's how I'm doing. And the fan is looking towards me and that thing. It doesn't make any sense, but they have these things called like loose associations, which are basically sort of run-on sentences where they associate two things that are unrelated very, very loosely, and they might sort of babble on in a way that doesn't make any sense. It's perfectly logic to them. It's perfectly logical to them, but within their own brain and the way their brain is making these connections, but to another person, it sounds like word salad, word soup. It just doesn't make any sense. Negative symptoms are also emblematic of schizophrenia, and they're often the first ones to manifest, especially when someone is first being diagnosed or first developing symptoms of schizophrenia. Schizophrenia usually develops around young adulthood, adolescence. So maybe between the ages of like, say, 15 and 25 is usually when these negative symptoms start showing up. So it can be a lack of emotion, monotone speech, and a loss of interest in everyday activities. So sometimes people might initially diagnose schizophrenia as depression even, before the patient comes forward with, say, the delusional thinking and hallucinations that are more emblematic of schizophrenia. So schizophrenia can't be cured, but it can certainly be treated with medications and psychotherapy. Let's start off, though. Let's rewind a bit to bipolar disorder. So pharmaceutical treatments for bipolar disorder include acute drug therapy and maintenance drug therapy. So we want to treat bipolar disorder as it first manifests. If they go into an acute bipolar manic phase or an acute bipolar depressive phase, and then maintenance therapy, we want to hopefully stop them from going into either that manic or depressive phase entirely. So we prescribe mood stabilizers. The go-to mood stabilizers are lamotrigine, valproic acid, and lithium. So lithium, or Lithobid for bipolar disorder, it's a mood stabilizer which prevents extreme mood swings. So it's very, very carefully dosed. You have to avoid inducing a mood swing in a patient, of course. So you have to titrate it up, slowly increase that dosage until you find the dose that works for the patient. And that's when you achieve the therapeutic effect. That's the effective dose. There's a problem with lithium toxicity. Lithium can displace sodium in the body because it's also a salt, very similar to how sodium is. And that can cause a significant toxicity risk. So we want to be very, very careful when we're dosing lithium. And it also has a lot of drug interactions. So you want to avoid ACEs and ARBs, those blood pressure medications that we talked about. You want to avoid non-steroidal anti-inflammatory drugs, or NSAIDs. So that's like our ibuprofen. Also avoid diuretics and even caffeine. And caffeine can also, as you can imagine, caffeine can set someone into a manic phase. It could be as little as that. So, but the main point, the counseling point I would say with lithium is you have to take it with food and plenty of fluids. Why do you take it with food and plenty of fluids? Because lithium can cause excessive urination, polyuria, and excessive thirst, or polydipsia. That's because it's cleared through your kidneys, and it can certainly cause that excessive urination, excessive thirst. So you want to make sure that someone doesn't get dehydrated. Lithium also, unfortunately, can cause weight gain. That's probably the main side effect that people would complain about, aside from having nausea and diarrhea. But again, that's dose dependent. And once you find that therapeutic effect, that therapeutic dose of lithium, usually that nausea and diarrhea goes away. We also have valproic acid, which is known by a whole lot of names, but mainly Depakote or divalproex. It's also a mood stabilizer for patients with bipolar disorder and prevents extreme mood swings. Valproic acid can also be used to treat seizures, actually. It's used in epilepsy as well, and it's mainly taken as tablets. It's important, you cannot use it in pregnancy. It can cause birth defects in babies, so always caution using valproic acid in women who are of childbearing age, or women who are pregnant or may potentially become pregnant. Also have to be careful with our toxicities. So our liver toxicity, pancreatitis, it can cause inflammation of the pancreas, as well as weight gain. So many times people do experience a fairly significant weight gain if they're taking both valproic acid and lithium, because those are side effects of both of those drugs. Common side effects, though, with valproic acid are nausea and vomiting and tremor. Sometimes people might shake a little bit if they're on valproic acid. Hair loss is also possible. Alopecia is the medical term for that, as well as anorexia or appetite increase. So it's interesting, like weight gain can be a side effect, but it can also cause people to lose weight. They don't have as much pleasure eating foods, and it can cause either an appetite increase or an appetite decrease. Next, we have our next class of medications, which are known as our antipsychotics. Now, these are medications that you'll probably see both outpatient and inpatient in a hospital. And they're particularly useful, not just for, say, bipolar disorder, but mostly for schizophrenia and some other mental health issues. So certain psychiatric mental disorders might cause people to experience a state known as psychosis. This is not what we're talking about when we think of like Alfred Hitchcock's Psycho, right? So psychosis is a medical term. It's a mental state in which people lose contact with reality. So it sounds a lot like schizophrenia, right? So schizophrenic individuals may end up undergoing psychosis, a loss of contact with reality if they're having an episode. So people with psychosis might experience hallucinations, like seeing, hearing, smelling, or sensing things that other people cannot, things that are not there, or delusions, which is believing things that are not actually true. So antipsychotic and mood stabilizing medications can give patients an improved quality of life, which is the ability to hold a job, even a conversation, no more word salad, and to participate in activities of daily living. It gives these people peace of mind and improved relationships with their family and friends, which they otherwise might withdraw from. So the first of our antipsychotic drugs that we're going to talk about is Haldol, or Haloperidol. It's what's called a first-generation antipsychotic medication, and it's used to treat schizophrenia as well as some other brain disorders. However, it's also very commonly used in emergency departments for behavioral disturbance or to treat acutely psychotic or violent patients. So if someone's really causing trouble within the emergency room, say they are a threat to the health and safety of themselves or others, oftentimes they may be given a Haldol injection to calm them down, to sedate them until they can be properly controlled with other medications. Now, you'll notice I said it was a first generation antipsychotic. Haldol is a super old drug. It's been around, I think, since like the 70s. And it has, because of this, it has a lot of side effects. So second generation or newer antipsychotic medications are generally preferred today over haloperidol for treating bipolar or schizophrenia. However, haloperidol is also quite often used, and its dosage forms are oral and injectable. So you can have weekly to monthly injections of Haldol, which when you think about it are really great for patients with schizophrenia who might have problems adhering to a medication schedule. The thing is, a lot of times patients with schizophrenia don't even think that they're sick, because why would you? They think that everyone's sort of conspiring against them, that it's well, obviously I don't have anything wrong with me. I'm seeing the truth in society and they're watching me and they want to put me on medication so I don't say anything. That's oftentimes what they think, unfortunately. So they might not want to take medication every day, especially if they're going through a psychotic break or a psychotic episode. So it's quite useful to have an injection that works over the course of weeks and months. A monthly injection of Haldol can be extremely useful. It's just administered in a doctor's office, and that gives schizophrenic patients, number one, a better quality of life where they don't have to worry about taking their medication. And number two, it's usually quite easier to control their schizophrenic symptoms because it's a long-acting medication that really doesn't wear off for an entire month. So they don't have to worry about taking the medication. They've got that good adherence, and then they just have to schedule that doctor appointment. Now, side effects and precautions. Haloperidol has a risk of movement disorders, otherwise known as tardive dyskinesia or EPS, which are your extrapyramidal symptoms, EPS or tardive dyskinesia. They're these irregular movements, almost like tics. If you've seen a person with like Tourette's disorder, they might blink, they might have a strange arm movement or a face movement. They might do something sort of weird with their tongue. And that can develop with long-term use of certain antipsychotics. Now, many antipsychotic drugs have a lower propensity to create these movement disorders, this tardive dyskinesia. However, there is a slightly greater risk using the first generation antipsychotics than the second generation antipsychotics for these movement disorders developing over time. Sedation and drowsiness are also quite common with Haldol, which is to be expected, right? Because it's also used for behavioral disturbances and to calm people down and sedate them in an ER. There's an increased risk of cardiovascular events as well with Haldol, which is why we generally try to avoid it in people who might be at risk for fast heart rate, stroke, or arrhythmias. This is especially common with the intravenous route as well. Akathesia or restlessness is also a fairly common side effect of haloperidol. Basically, the patient cannot stay still if they have this restlessness. And then Parkinson-like symptoms, because it works in the brain and can cause sort of the Parkinsonian mask face, sort of shuffling gaits, those types of Parkinson types of movement symptoms as well. So next we have our second generation antipsychotics, or SGAs. So they are used to treat both bipolar disorder and schizophrenia. So that's what sets them apart from those first generation ones. And what makes them different from the first gen? So they have a lower risk of those movement disorders that I was describing. So lower risk of EPS, lower risk of tardive dyskinesia, and a lower risk of those Parkinsonian symptoms and tremors. However, there is a trade-off. SGAs have a higher risk of metabolic disorders. What is that? Mainly weight gain. People can gain a whole lot of weight when they're taking these SGAs. Now, it's a small price to pay to be able to function in society and to not have bipolar or schizophrenic symptoms. However, people might not like that weight gain. So, and with the caveat that these side effects vary greatly depending on the second generation antipsychotic which you're using, there are potential side effects still of movement disorders. Those metabolic side effects include weight gain and an increased risk of developing type 2 diabetes, especially if someone maybe was pre-diabetic or was on the cusp of developing diabetes. Unfortunately, those SGAs might just push them over the edge into diabetic territory. Dyslipidemia, or an increased cholesterol level, might also be a side effect that goes along with those metabolic side effects. Orthostatic hypotension, or dizziness upon standing, is also quite common with SGAs, as well as an increased risk of arrhythmia or irregular heartbeat. So an increased cardiovascular risk is quite common with some of these SGAs. Excessive salivation as well, or drooling, is also a symptom or a side effect of some of the second generation antipsychotics as well. It was actually interesting. One of the main ones that causes this is Seroquel or Quetiapine, very, very commonly prescribed. But there's a story that I like to think of with it is that when they were first deciding and putting it through drug trials and trying to blind those drug trials, blinding meaning you didn't know if the patient was receiving a placebo, a different drug, or the actual quetiapine or Seroquel, which was supposed to be used as the antipsychotic in this case. They couldn't effectively blind it because all of the Seroquel patients were drooling. So the doctors figured out, well, obviously they're on Seroquel because that drooling is a side effect of the SGA. And obviously you don't need to know this, just appreciate the differences, but you can see the differences in the extrapyramidal symptoms, the CV symptoms, those cardiovascular symptoms, and how they vary. Those 3 dots mean that they're very, very frequent in over 30% of patients. The 1 dot means it's negligible or almost absent. So for instance, if you have a patient who is at risk for movement disorders, you might want to prescribe them quetiapine, olanzapine, clozapine, or aripiprazole, Zoprazone, rather than haloperidol if you notice that they might be at risk for developing those mood disorder or those movement disorders, because there's a lower risk when using the quetiapine or the clozapine. And similarly for other side effects, we like to take that into consideration before prescribing a specific antipsychotic for these patients. Now, we have examples of second-generation antipsychotics here. These are your probably the most commonly prescribed, the ones that you might be liable to see on the exam. We have aripiprazole or Abilify. You can see in the commercial, they talk about how like, oh, well, some people had symptom improvement as early as 1 to 2 weeks based on 6-week clinical studies, and results may vary. You'll notice they always do those little disclaimers in the drug commercials. Clozapine is notable, or Clozaril is notable as sort of the best second choice antipsychotic. So if the first treatment fails, if you try treating someone with the Abilify or the olanzapine, the quetiapine, and that doesn't work, usually about 90% of the time, if you switch them to clozapine, it will work. So it's known as the best second choice. Next, we have olanzapine or Zyprexa, and that is generally considered the worst for metabolic syndromes and weight gain. So you would avoid this person if they're maybe more at risk for diabetes or a similar metabolic disorder. And oftentimes with olanzapine as well, people might have to go on a specific like low carb diet in order to stop gaining too much weight. It's available as a tablet or a orally dissolving tablet as well, which is good for patients who might have problems taking pills. And it's also available as an injection. Next, we have our quetiapine or Seroquel, again, super commonly prescribed, available as a tablet or an extended release tablet. Risperidone or Risperdal is also a tablet, an orally dissolving tablet as well. Also a liquid and available as an injection. So again, quite useful if the patient is maybe not at risk of non-adherence to their medication. And then Zoprazone, the only main thing with Zoprazone, it's not that commonly prescribed, otherwise known as Geodon. It's not that commonly prescribed because of the very, very large cardiovascular risk. So if someone's at risk for a cardiovascular or a heart issue, you avoid Zoprazone with them. And it's available as capsules. So I understand that's a lot of material to keep up with, but feel free to ask any questions. Have a good one.